So mabuhay to everyone joining us from across Asia and around the world. On behalf of the Asian Society of Pediatric Anesthesiologists, welcome to this ASPA-FLEX webinar, aligned with the WFSA Presidential Theme 2026 to 2028, the Pediatric Anesthesiology Along the Patient Pathway. I am Teddy from KK Women's and Children's Hospital and Philippine Children's Medical Center as well. And it is my pleasure to moderate this afternoon's session. I would also like to acknowledge and thank Dr. Vibhavari Naik, who is serving as our co-moderator and IT support for today's webinar. Dr. Vibha is a senior consultant and on-call anesthesiologist from Basava Tarakam Indo-American Cancer Hospital and Research Institute in Hyderabad, India. She is also a past secretary of ASPA, editor of IAPA newsletter, and lead for WFSA Presidential Theme Initiative. Thank you, Viva, for all your support and making this webinar possible. All right. Traditionally, pediatric anesthesiologists were often viewed as specialists working mainly inside the operating theater. But increasingly, our role extends far beyond the anesthesia delivery itself. We are now involved across the entire perioperative journey, and from preoperative optimization and patient blood management to ERAS pathways, pain treatment, rehabilitation, and helping children safely return to daily life. So tonight's webinar reflects that evolving role through the discussion of a child undergoing scoliosis correction surgery, one of the most multidisciplinary and complex perioperative journeys in pediatric care. More importantly, this webinar brings together experts and participants across Asia and beyond, highlighting the strength of collaboration, shared learning, and our common goal in improving outcomes for children. We are truly honored to have our outstanding faculty joining us this evening, and we thank you all for spending your time with us. It is now my privilege to introduce our speaker and panelists. First is Dr. Brushali Ponde. She is the Director of Children's Anesthesia Services in Mumbai, India, and Program Head of WFSA, AORA, and CAS Pediatric Regional Anesthesia Fellowship. She's also, of course, our current President of ASPA and the Vice Chair of WFSA Pediatric Anesthesia Committee and a respected international leader in pediatric regional anesthesia and perioperative care and education. Next is Dr. Serpil. Dr. Serpil is a senior anesthesiologist in Acibadem Health Group, Istanbul, Turkey, and immediate past president of ASPA. She currently serves as chair of WFSA Pediatric Anesthesia Committee and is actively involved in ASPA's education, sedation, POCUS, and regional anesthesia initiatives. Next of our panelists is Dr. Norifumi Kuratani. Is the anesthesiologist in chief of Saitama Children's Medical Center, Japan, and clinical professor of Tohoku University School of Medicine. He is actively involved in WFSA and ASPA initiatives with interest in pediatric anesthesia, TIVA, emergency agitation, global health, and advancing safe pediatric anesthesia worldwide. Next is Dr. Ina Ismiarti Sharafuddin, is a professor of University Malaya and senior consultant at University Malaya Medical Center, Malaysia. She is the president-elect of ASPA and an active member of the WFSA Pediatric Anesthesia Committee, with strong interest in pediatric airway management, quality improvement, pediatric level transportation, and medical education. Dr. Ekta Rai is a senior professor of anesthesiology at Christian Medical College, Belor, and currently leads the WFSA Education Committee. She is also the president of ISA Tamil Nadu State Branch and conference chairperson for ASPA 2026. So Ekta will be welcoming us this coming September in Belor, with interest in pediatric thoracic regional anesthesia, POCUS, simulation, and medical education leadership. Lastly is Dr. Melody Long, is a senior consultant in the Department of Pediatric Anesthesia at KK Women's and Children's Hospital in Singapore. Her clinical interests focus on pediatric anesthesia, perioperative care management for children. Now, to discuss a few housekeeping reminders for our audience, I'll hand over the screen to Viva. Hi, Viva.
Hi. Thank you, Teddy. Very warm welcome to all our viewers across Asia and beyond. And before I take them through the housekeeping rules, I just wanted to share a few thoughts on the theme, the ethos of this webinar, which, like Teddy said, is gradually anesthesiologists are moving beyond the OR. And it's extremely important because not just that they improve the patient outcomes, patient experiences, but also the fact that it increases the visibility for us as a profession, anesthesiologists, and it allows us to work towards more collaborations and probably robust healthcare systems. So now, taking you through the housekeeping rules, intentionally, this webinar has been put up as a panel discussion, and we would really encourage your thoughts, your questions, your comments. And the way you can do it is to enter through the Q&A section. Please note that the chat and raise hand function are disabled. So Q&A section is the way that you could reach out to us. While we'll try and take a few questions online, our panelists would answer. There could be a few that some of us might want to answer right there and then in the Q&A section. Also, I wanted to share that we are going to have a few polls during this webinar. And whenever a poll is launched, you would see the poll on your screen. You will be prompted to answer. You would have 30 seconds to respond and submit the answer. Once the poll is complete, the results would be displayed. But remember that after the results are displayed, you would have to click the close button on the poll so that you can continue seeing the slides that are shared by our speakers. And like always, the certificate of attendance is going to be automatically generated and forwarded to those of you who submit the post-webinar survey. The survey is going to be available 24 hours after the end of this webinar. Please remember to correctly enter your full name and your email address to receive the certificate of attendance. And disclaimer, as always, for all our ASPA-FLEX webinars, that the information presented in this webinar is intended for educational purposes only, is not meant as a substitute for professional medical advice, diagnosis, or treatment. The views expressed in the presentations and discussions are those of the presenters and panelists and do not necessarily reflect the opinions or policies of any institution or organizations to which they are affiliated to. And additionally, the information presented may not be applicable to all individuals and situations. Right, and with this, we are going on to begin our webinar. First, we are going to request Dr. Vrushali, who's the president of ASPA, to share her thoughts and views on the theme of this webinar. So over to you, Vrushali.
A warm welcome to all of you who have logged in today and those who would visit this webinar in the future via our YouTube or website. So I'm Dr. Vrushali Ponde, and I am serving currently the Asian Society of Pediatric Anesthesiologists. I welcome you all to a very different webinar, as it were. This webinar is about pediatric anesthesia patient pathway, and this is in alignment with the presidential theme of the WFSA. This is something that we already always did. However, we are going to give it a structure and present it to you in a very pragmatic manner via a quintessential case. So wait for that when the webinar begins. Now, let me just walk through you to the pathway so that you are very well prepared for the webinar that you are now going to attend. Let me just share my screen and allow me to share my thoughts with you. So this is how it goes. The pathway consists of many things. However, before that, I want to share a story with you. Long back, in the southern part of India, we had huge amount of floods. And this is what happened. The army was called to rescue, and they rescued even small infants and children from the danger zones to somewhere which is safe. Here is an example where an army person picks up a child and gives back to the mother in a safe manner from a so-called hostile environment. Doesn't this give you a similar? Almost let them get them to the surgery, let them go through the surgery under our wings and give the baby back to the family. So this is what, in fact, we are doing. And there are various time points or pathways that we follow. And now let's look at it. So in other words, what are we doing is, evangelizing the ex. We would love to make them love our interaction. We would be happy doing what we are doing. Be happy to do. So we are safety granted. We are here to deliver something far more and experience, Angela, of administration and so on and so forth. So this is the pathway that we follow. I repeat, we have been following, but today, of course, we have an opportunity to put it in the first is operative phase. Of course, no anesthesiologist ever is going to without a pre-op visit, no matter if it's 1 or 2. So yes, there is a family, your tuition, you assess it, you observe it, and you have your plans ready here. The intraoperative phase, needless to say, so much goes into that phase, and this is what we are absolutely trained to. These phases we are trained to. Postoperative phase. Now here is something that we can go walk a little mile ahead to understand what we can do here. We can continue providing pain management. We can continue providing so many things here. Let's see what. Now we can go even beyond the OR, and then we, of course, learn, train, teach, and lead in so many ways when it comes to pediatric anesthesia. Now, in pre-op phase, of course, we assess, we optimize, we plan, we risk stratify. We have a planning of anesthesia. We share that with the family and, of course, with the surgeon or the intensivist, and counsel the patients and the families. And, of course, we pre-medicate whenever, as and when made possible. Intraoperative phase, this is what we are traditionally associated with, but of course, now it's far more than what we do. Induction and maintenance, monitoring, managing fluid, blood loss, emergencies goes without saying. Postoperative phase, immediate postoperative care, recovery, pain control. We can manage nausea, vomiting, airway. We know this very well. These are our everyday drugs. ICU and recovery room care. That's where we can extend ourselves. May it be a neonate, an extremely super neural catheter. We have put pump, but go back visit for pain. We go back later, ask a pain agent or our infusion is required. So we can get involved as a team in all this, and that would be really more beautiful and satisfying. So when we do this, we are in constant communication with the surgical team, we are in constant communication with the staff on the floor, and of course, meanwhile, while we're doing this, if we have students, we actually pave way to legacy. So this is what is happening. Few of the WhatsApp conversations as testimonials for you to realize that, look, this is what we can do with our everyday work. It can metamorphose into something far more meaningful. And then you get a bit of compliment as well, in which you actually can choose to bask, or if it's criticism, you can choose to take it constructively and evolve, which, yes, we all have done with grace. So, yes, all your patients always have a smile on their face whenever I visit them. Look, if you get something like this from a resident in surgery or their boss, well and good. Madam, I start my work as in the hospital. Oh, good. Yes. Look at this. So who doesn't look at me? And beyond the OR, this phrase is something more meaningful. Look at it. You can go into pain medicine and deliver critical care, perioperative medicine pathways, enhanced recovery in ERAs. So much can be done by anesthesiologists in ERAs and focus and monitoring outside the OR. So, this is one freak case where the Foley's catheter balloon refused to get deflated. And finally, I happened to do a percutaneous puncture and, yes, finally solved the point where everything was stuck and the child was in agony. Extend your skills in regional anesthesia and relieve ischemias in NICUs or PICUs wherever possible. So these are just one or two examples, and I'm sure each of you can come up with so many from your daily practice. So physicians who influence outcome across the entire perioperative pathway can be a pediatric anesthesiologist in this given situation. So along with so many work. So learn, teach, need a course. Very, very listen to this. This is an art, you see, and I'm so sure you're for that. So enjoy.
Put Dr. Brushali's pathway in a more clinical context. We chose one case that our panelists will discuss as we move forward to a different section of this webinar. So let me share with you the case that we will be discussing this evening. Okay, so this is a 13-year-old girl with adolescent idiopathic scoliosis and is referred for surgical correction at the tertiary pediatric hospital. She weighs about 39 kg with a Cobb angle of 68 degrees thoracic curvature and progressive deformity over the past year. So she reports increasing back discomfort, exercise intolerance. So then her medical history is otherwise unremarkable. Although she has a mild iron deficiency anemia detected during surgical workup. Her pulmonary function test demonstrates moderate restrictive lung disease, and which is expected given the degree of the thoracic deformity. So please do remember this case because most of our discussion will evolve around the pathways. So, I mean, we need to, before we actually ask our panelists, maybe I will share first our first poll question. So, our first poll question to our viewers, right? So, at your institution, right? At your institution, when does perioperative engagement usually begin? Is it before surgical listing, the moment that the patient is seen by the surgeons and all that, or during the pre-anesthesia review, on admission on the day of the surgery, or in your institution, you don't have a formal early engagement process? So while you are answering those questions, let's go back to the question I just shared just now. Maybe I'll ask Dr. Melody. At what stage should anesthesiologists ideally become involved in complex pediatrics spine surgery pathways? Dr. Melody?
Hi everyone, I'm Melody. I think for this particular question, it's important to understand for this complex spine patient, are we talking about an idiopathic scoliosis patient or we're talking about a neuromuscular scoliosis patient? And I think the difference is important because for a neuromuscular scoliosis child, we should be involved the moment the surgeons are thinking of operating on the child, perhaps in the next couple of months. Because in a neuromuscular spine, for example, there needs to be a wider group of multidisciplinary medical professionals that will need to weigh in on the management of the child. We may need preoperative cardiac investigations or respiratory investigations, and these sort of discussions, it's better to have a longer runway. However, if it's an adolescent idiopathic scoliosis child, in general, these children tend to be quite well. So for these children in our institution, we will see them in the pre-anesthesia clinic at least 2 weeks before their planned surgery. And the purpose of that visit really is to give these children and their caregivers an expectation of what the perioperative journey is going to look like. And I think that's very important to help to set them up for success. And because when they have an impression of what things are going to be like, it is far greater, more likely that they will be able to cooperate with the physiotherapy and knowing that they do need to cooperate with certain parts of a clinical pathway in order to get home sooner. Thanks, Teddy.
Yeah, thank you, Melody, for that sharing. I just go back to the result. I'll just share the result of our webinar. So majority of our attendees actually answered that at their institution, perioperative engagement usually start at the pre-anesthesia review. Dr. Melody shared about identifying whether this is adolescent idiopathic or this is neurogenic scoliosis and all that identification. So then, Dr. Melody, what do you think about the result? 69% is the pre-anesthesia review. Do you think that do we need to see them earlier than that or before the surgical listing, or during this pre-anesthesia review is adequate enough for anesthetists to review the patient or the first engagement?
I think if it's an idiopathic scoliosis during the pre-anesthesia clinic review, I think that's potentially sufficient. But if it was a more complex child, like a neuromuscular scoliosis child, then I think it should be before surgical listing, just like how 19% of our response have that practice in their institution. Having said that, recently our spine surgeon, after completing her training in France, has initiated having a parents and patient support group where even the adolescent idiopathic scoliosis patients would come together. We kind of bunched them based on them getting surgery in the next 6 months or so. They come to hospital, they sit down, they take a mini hospital tour, they listen to Dr. Teddy about our pain pathways and what to expect in terms of pain after the surgery. Coming in for surgery or certain frustrations them to bring up to a doctor if their fear at this peer level meeting. It gave them a lot of support and it brought up opportunities for them to ask silly questions, so as to speak, and use that as a chance to prepare themselves psychologically better for the surgery. So from that perspective, the engagement may not be with the person.
I have to agree with Melody on that in a sense that engagement should not be exclusive as it is engagements of what potential outcomes and what to expect along the way. Dr. Ekta, what do you think? In India, how do you actually engage our patients? Not necessarily spine surgery, let's say other surgeries, which is complex that require multidisciplinary approach. How soon or how early do you approach the patients?
Actually, I'll just take Teddy. Hi, Teddy. I'm Ekta,
Hello.
and it's a pleasure to be here. And I'll share my experience in our hospital. It's a little different from as what Dr. Melody said. Very clearly, this child, though, is AIS, but he has got a very significant deformity, Cobb's angle of 69 degree. Also has got a restrictive lung disease. So what happened? Such patients actually are, the moment they come to surgeons in our hospital, the surgeon of that unit alerts the senior most anesthetist of that unit. And that's how we get involved way earlier than when they come to PAC, which is pre-anesthesia clinic. And the initial evaluation happens actually at the time when the patient is seen by the surgeon or maybe the second visit of surgeon, not in the pre-anesthesia clinic, but a little earlier, which is mainly to highlight whether what kind of optimization is required, if you need to do some investigations, and also to sit with the patients and relatives, the parents, and sit down and say, post-op, are you going to go to ICU? Are you going to have some catheters? How long you will be requiring leaves? And the basic discussions, most of the basic discussions happen with the surgeon. But then after this, perioperative scenarios like how's the pain going to be? We will keep you and kind of developing confidence in anesthesiologists. I think pretty much other things that Dr. Melody said. This is what we do. Generally, we like to have a multidisciplinary meeting a bit earlier with physiotherapist, and there we call the parents. If not every time the child, but parents do come for that.
I think we are already moving to our second question. So yes, I think Ekta already mentioned a few answers to our second question. We said how can early anesthesia involvement improve patient counseling, risk communication, and perioperative planning as well? I'll go back to Dr. Melody on this. I mean, in your patients that you've seen, right? How do you think surgeons will even invite them in a lunchtime or a tea time at hospital? How
Sorry, Teddy, I lost the last part of your question. I couldn't.
improve our patient counseling and outcome planning for the patient perioperatively?
I think the biggest contribution early anesthesia involvement has is in expectation management. And when expectation management is done well, the entire perioperative journey then becomes smoother for the patient and also for their family. So when we can manage expectations, we can tell them, okay, when you come into the hospital, this is what you're going to be doing. This is what's going to happen immediately after surgery. I expect you to get up and walk on the first day after surgery, but we will give you good painkillers and we will support you in that journey to moving. And then when you keep stressing to them that movement is medicine, it's very important that psychologically they need to accept that there will be pain, but it will be controlled, it will be managed. And with that, I find that it's much easier for the patients to then be able to accept that whatever happens to them in the perioperative period, it's normal. So we normalize feelings of being scared of pain. We normalize feelings of hesitancies around moving after a major surgery so that they can then think to themselves, medical team to do so, and therefore have confidence in being able to help themselves to get better. Also, when we are involved early, I think the parents and the patient can also use this as an opportunity to develop a relationship with the hospital system, and through that be able to see what sort of resources they can gain access to. So if I'm allowed to share some resources that we use in our hospital, I'll just be sharing my screen right now.
Yes, please. Thank you.
All right, so over here, you see that we have got a QR code. This QR code is actually a preoperative scoliosis video that we have prepared for our patients who are coming in for scoliosis surgery. This video can actually be, it's actually available to the patients to see. You can scan this QR code and look it up. It's a YouTube video. And also, we have got the scoliosis passport for our children and adolescents. And in this passport, it kind of walks them through the journey in which they'll be taking with us when they come in for scoliosis surgery. It gives them a bit of information about what scoliosis is, what the treatment options are, and some of the stages which are involved, such as bracing, physiotherapy, and the actual surgery itself, and then some information about discharge and even home care. And lastly, we do have a pamphlet for intrathecal morphine. In the last year or so, our institution has moved towards using intrathecal morphine as a form of pain relief for scoliosis surgery. And this is a little pamphlet that we prepare and pass to our patients in the preoperative setting so that they can take this pamphlet with them. They go home, they can think about it, they can digest the information. And when they actually come in for the surgery itself, they are then prepared for what it is that they will be receiving in terms of pain relief. And it's also a wonderful opportunity for them to be able to ask questions if they have got any when they have received this sort of material. So I'll stop sharing right now and I'll hand the time back to Teddy.
Thank you very much, Melody, for that sharing. I think long and short of it, what are we trying to share to our viewers, that we must, as early as possible, that we need to develop rapport, set the engagement, and then provide adequate means, may that be in videos, pamphlets, educational materials, some small gatherings from different patients and parents, of course, in order for us to manage their expectations, to get them involved, and have them understand what are the things that they need to do in order to recover well. Because at the end of the day, we need to let them picture the end point of this journey so that as early as possible, they already have a clearer journey ahead, how they are actually going to do that as well. So now that Dr. Melody and Dr. Ekta somehow gave us an early preview of what we...
Sorry to interrupt, Teddy. I just wanted to say before we move on from this topic, there's a question for Dr. Melody.
Great.
Someone wants the resources. So if you could just type in that reply, Dr. Melody. Sure, thank you.
Oh, yeah, okay.
Over to you, Teddy. Yeah.
Right. Thank you, Biba, for that. Yes, of course, like I mentioned, Dr. Melody and Dr. Ekta already gave us a preliminary, or let's say, discussion about how early we should actually engage our patient and how we will going to manage their expectations. Now that we are there, now we will move on our discussion for the preoperative planning and optimization and rehabilitation. So I think for this one, our first question is that how should these patients, because the patient do have an iron deficiency anemia, right, be managed within the patient blood management framework? Before I invite our panelists to answer this question, let me share first a poll question to our viewers. So we would like to poll our viewers regarding iron deficiency anemia. So based on your current practice, right, how do you actually manage pediatric iron deficiency anemia? Do you actually request for a blood transfusion, or you wish to delay surgery, refer to hematologist for optimization, and once there is already a plan for the iron deficiency anemia, then that's the only time you will schedule the case. So while we are answering that, okay, we will give everyone some time to think about that. So 10 more seconds, and then we will share the results. All right, I think the 30 seconds is up. I will end the poll and share the results. All right, okay, so from here, based on our answer from our viewers, 47% will prescribe oral iron therapy, and 26% will delay surgery for optimization. So maybe let me invite Dr. Ina, Prof. Ina. Would you like to provide us some in your institute? How this
Hi, I'm from University Malaya Medical Center, Malaysia. Thank you, Teddy, for this opportunity. So when we talk about iron, we do not know whether this patient have iron deficiency anemia. We are assuming, right? We just know the HB is 10.2. So ideally, we should do iron test on this patient to see the ferritin level. And if you do not have that test or it's expensive, there's also other tests you can, simple microcytic anemia or macrocytic anemia. It can give you some form of a sign where what sort of anemia it is. Then, and we know that scoliosis is an elective surgery, so that it's not very time sensitive. So if when planned well, we can actually optimize this patient, right? So I'm very lucky. My team of surgeons for spine here is actually very good and they are well renowned, and they have their own streamline of tests that they do before they actually call us. And if they will actually detect all this before they send to us, and they would have started their oral iron therapy like 6-8 weeks before. So they have time for these children to actually build up their own HB again. But if in any circumstances, for whatever reason, if after the oral the oral iron, it doesn't pick up, then they have to investigate, is this patient losing from anywhere? And if there isn't any reason, then if they could not wait for whatever urgent reason for surgery, which I don't think there is really, the other option is to do an IV iron for this patient. IV iron, the problem with us in Malaysia is actually the cost. It's good if you can provide IV iron because you don't have to go through the long waiting time to build up the iron in the patient system. But in Malaysia, it's slightly on a higher cost. So if we can, we will treat with oral iron before that. So if you talk about PBM, IV iron is just one of it. That's the first pillar, identifying anemia, treating it, and then optimizing it. But you also have to look at the other pillars, which actually doesn't really go preoperatively as much. But you can, it's a pillar 2 where you want to minimize intraoperative blood loss. So we have to discuss with surgeon. It's a multidisciplinary, as all our 2 colleagues, Hector and Melody, has mentioned before. It's multidisciplinary, so they would know the role of good coagulation, good surgical skill, tranexamic acid, and then we also use in my center cell saver. So spine surgery is where the usage of cell saver in my center is almost routine. And then after that, of course, the pillar 3 is we optimize the tolerance for post-op apnea. This is where I think it will relate to what others are going to talk about, the oxygen demand and the post-op pain relief, to reduce stress and whatnot. Yeah, so I hope I answered that part.
Thank you very much, Prof. Ina, for that very comprehensive iron deficiency discussion and treatment as well. So maybe I can ask Dr. Serpil, how about in Turkey, in terms of management of patients coming in for iron deficiency anemia?
Thank you, Teddy, for this opportunity. I'm Serpil from Turkey, but I live in and work in Istanbul, one of the largest cities, and I can say that in Turkey there are different managements, like in all globally, it's different, I think. It's very hard to optimize sometimes these kind of patients in some parts of the world, like Ina said. Of course, this patient has anemia and should be treated beforehand, but sometimes it cannot be. Like I'm working in a private hospital, sometimes the patient comes on Friday and the surgeon says that we should operate him on or her on Monday. So we won't have any time to optimize the anemia. I believe in some parts of the world, this is the similar scenario. This is a teamwork. So these patients should be planned earlier. And like Ina said, and Melody has mentioned earlier, the hospital has to be involved also, the administration, the team. In your hospital's autologous blood transfusion, do you use these kind of managements before these kind of operations?
addressing to
Do
the
you use
panelists?
Yes,
Anyone
panelists.
I can say it. So somewhere in 2009 and 10, we used to do ANH where we used to, take off the blood and then keep it and transfuse. But now it's not practice anymore.
Not practicing.
Yeah, but because we are in institutions, so it's easy for us. Our surgeons will not take patients with anemia. But I understand in
great.
private practice, it can happen. Yeah.
Yes.
But I do think if you want to
Ina,
do acute normal volumic hemodilution, you still have to start off with a good HB. Because with a 10, if you take 400 mils of the child, it will certainly drop, and the risk of transfusion is still there. So unless you want to use cell saver and then whatever you lost is being taken back, then we may be reduced the risk of transfusion there. Yeah, that's my take.
Even with cell savers, I think after the operation, the postoperative anemia, this child goes to the wards, and it's hard to manage the postoperative anemia, and blood again is transfused. So I believe this is a way of belief and the teamwork. Again, the teamwork that every patient is specific in herself. So yes, it's right not to take the patient with 10 HB. We have strategies to refrain from blood transfusion, but sometimes I see that in youngsters, or not youngsters, but who are applying PBM, they refrain from giving blood, but this have the danger of hypovolemia, or during the operation, blood loss is very significant, and if they don't give blood, then it will be a disaster. So to be in the safe place is always mentioned.
Yes, thank you very much, Ina and Dr. Serpil, for
Can I share my experience?
Yes, Dr. Nori. Yes, please.
Yes, Nola.
Yes, let me share our experience in the ideal world. In Japan, we have ideal. We have school system for school patients, students. So that means all students from elementary school to high school, they have a scoliosis screening every year. So that means most of our patients are identified at a relatively early stage, and they are usually followed by orthopedic surgeon, and the surgical schedules are carefully determined. So if unexpected anemia or other medical conditions issues are detected, usually early intervention is usually initiated during the follow-up stage. So as a result, it is relatively uncommon for us to encounter the significant untreated anemia when the patient came to our perioperative clinic. So if unexpected anemia is identified during the perioperative assessment, we will usually consult with the orthopedic surgeon about the surgical schedule.
I see.
And in our hospital, usually the otherwise healthy idiopathic scoliosis patient usually come to our pre-op clinic 1 month before surgery. And so we have some time to evaluate and initiate the intervention.
I see.
Same in my center. They will come very early to the surgeon, at least 8 weeks, and then to us 3 weeks before. So it's a good teamwork between the surgeon and the anesthetist to detect this. And my center also do private work. And I said the surgeon themselves identify this as an issue that they have to control with, so they also would not refer patient who is anemic very late to us to do. So I suppose that means teamwork is very important and paradigm shift.
Teamwork and
This
early
is not
recognition.
always.
Yeah.
This is
I'm
not the,
lucky.
And team,
this
before
is not
we
the
move
usual
on,
case.
sorry,
Yeah.
no, I
Yes,
just
Eva.
wanted to say two more questions related to blood loss. So maybe Ina, Dr. Nori, or
Okay.
anyone can answer. I think one is regarding hypotensive techniques of anesthesia to reduce blood loss, and the other one is the dose of tranexamic acid. So, Ina, do you want to go first?
Okay. Yeah, we do practice hypotensive technique, but we have to base it on the patient. You have to maintain certain BP, not severe hypotensive, but we do practice hypotensive anesthesia to reduce blood loss. And for the tranexamic acid, we routinely give tranexamic acid to children, and the dose as what recommended 10 to 15 milligram IV bolus, and then over 10 minutes, and then we do the maintenance between 5 milligram per kilo per hour throughout.
I see. Anyone
Same.
else actually doing a
The
hypotensive?
same.
Yeah.
Yes,
If you
yes.
think hypotensive, right? How low is? I mean, what is the magic number?
There's no magic number, right? And that's children. You have children like 9 years old, 12 years old, 18
Yeah.
years old. So
So
you
are we
look
allowing,
at,
let's say, 10 to 20% decrease from the
Yeah.
baseline or something
Yeah.
like that? So roughly we are going towards that direction, right? So we should know
Yes.
the baseline, and then from the baseline we roughly gauge how
Yeah.
low we can decrease the blood pressure and heart rate as well. So mainly, yes, Dr. Ekta, you raise your hand.
No, regarding that deliberate hypertension, I just wanted to say the latest edition of update in anesthesia has come up on PBM, and whatever little evidence, not great evidence, but whatever little evidence is not supporting deliberate hypertension. So the latest is not to have hypertension while the surgery going on, and avoid. There's no deliberate hypertension is support of deliberate hypertension. I just wanted to say that.
Dr.
May I add a
Yes,
line?
Dr. Bashali, yeah.
If it is all right. Yes. Actually, I was just about to say what Ekta said. I think a profound analgesia is something that really works. We need not really go to hypotensive anesthesia, and if we go too low, then it in fact would also hamper their neuro monitoring, and they would ask you to bring up the blood pressure, the MAC, to a certain level. So I don't think we're going anywhere very deep with pressures, I feel.
Normally,
Maybe MAC of 60 should be good. 50 to 60 should be good if we are really looking at figures.
Yeah, very true. I agree.
Dr. Serpil, you raise your hand.
Actually, during my residency, our teachers keep saying there is no hypotensive. So, but I don't. Some part believe this. The position is important, and if, as Burshali stated, that if you have the balanced anesthesia, like with propofol and remifentanil infusion, and if you can monitor the depth of anesthesia or near infrared spectroscopy, so you will have some weapons to measure how the perfusion is going and the depth of anesthesia is there. So then your anesthesia will be deep enough to prevent bleeding.
Yeah. I think the most important thing now, I think moving forward to advanced technology and all that, we are moving towards goal-directed therapy rather than hypotension itself. Now that we have awareness, gauge, perfusion gauge. You have all of these numerical numbers that guides us in our practice that geared towards the patient's ensure that the patient is perfusing and adequate depth. And of course, neuromonitoring is not compromised. Then I think we really need to move towards that rather than having a target of hypotensive technique in a way. So more of a goal-directed therapy and intraoperative management. Yes. Yeah. Okay. So I think we're slowly moving to the intraoperative management now. Let's go back and gear back again to the preoperative component. I think one of the questions that we wish to highlight is about pre-rehabilitation. So I think I'll go back to Dr. Ina about the value of prehabilitation in role in improving post-operative outcomes in pediatric spine surgery. It could be spine surgery because we're discussing this case, but if you have other cases to share, it's also welcome. Dr. Ina?
So let's go back to what we mean by prehabilitation. It's a concept where we build the physiological reserve of the patient before the surgery. So in this patient, as you can see, she has a poor pulmonary lung reserve, and she's going through to a surgery that will actually make the lung worsen sometimes, and she has to recover from it. So we need to have prehabilitation for this patient. So when we and ERAS, actually, I mean, in my center we don't have a protocol for ERAS, but we sort of for spine surgery, but we do look into all this as single pathway. So what we look at is we improve the physical conditioning, Most of the patient, because they have been seen by the surgeon earlier, they will be assigned with exercises they need to do. Some of them can afford personal trainers, so we refer them to personal trainers. But if not, we get them to come to our physiotherapists and have exercises. I teach them on certain exercises to do to improve their lung function and whatnot. And then it's very important for them to, this girl is very skinny in a way, isn't it? 39 kilo for 13 years old. So you need to have good nutrition to heal, to come out from big surgery. So we need to refer to dietitian, optimize the nutritional of this patient well. So we do that in the prehab duration. And then psychoeducation. Just now, I think Ekta and Melody has mentioned that, there's various ways that you can actually psychoeducate this patient, either by parents meeting parents and children meeting children. I think we haven't reached that yet, Melody. But we do have some referral if needed for them. My team, my surgical spine team have a Friday spine clinic where it's a multidisciplinary clinic where they get everyone down. Anesthesiologists not necessarily to see all patients, only the one that they feel they cannot manage. But the rest, they will be meeting the dietitian, the psychoeducationist, for this. And last but not least is, of course, the respiratory rehabilitation, where they will be taught on how to do incentive spirometry and all that to build their capacity. Yeah. So
thank you very much, Dr. Ina, for that very comprehensive answer on prehabilitation. You already included the optimization of lung functions and all that, mobility, and of course, meeting the parents as well. I think in the interest of time, we will move on to intraoperative. There's a lot of questions in the Q&A, but everything is, the question is more of the intraoperative management. So that's why we will move to the perioperative discussion and intraoperative discussion as well. So for this particular section, Dr. Ina mentioned about ERAS pathway earlier on, as early as a preoperative intervention. So maybe I will ask Dr. Serpil first regarding what are the essential components of ERAS pathway for pediatric spine surgery. Yeah.
Thank you, Teddy. For ERAS, I think the principle is that increased patient involvement. So to have the patient in the medical procedures, I think we try to educate and explain what's going on, like Melody, and it's done in KKH Hospital. Improved communication between team members should be implemented. And if we are consulting some other specialists outside, they should be in the team. In scoliosis surgery, we do this, and also in our cleft patients, we have a group of like dentists, speech therapists, surgeon, anesthetist, and families, all inclusive a group, WhatsApp group, so that the patients are discussed. But the ideal way, I think Melody has stated, to discuss all the process from decision to the late postoperative period, all the members should be included. We can call it perioperative surgical home or perioperative medicine or ERAS, what is called. It's to deliver planned and standardized approaches. So to tailor the needs of the special patient. This patient is, and usually the scoliosis patients are adolescents. So they will not be obeying what their parents saying. They will not listen to us. They will do whatever their friends will say. So the groups are very important. Their peer groups are very important. Who has experienced these before are more believable than us. So the components are the preoperative teaching, both the parents, the patient, and setting the expectations. What will the operation be? What will be prepared before the operation? What you will do with the exercises, and what we will gain from them. And our approach, our anesthetic approach, should be a standard way, intraoperatively and postoperatively, and surgical management should be standardized as well. And also the immediate period to the long-term postoperative period, the management of the pain and all the complications like nausea, vomiting, early feeding, clear fluids, early standing up, should be all discussed beforehand.
Thank you very much, Dr. Serpil, for sharing with us the components of it. I think maybe I should ask Melody, anything else that you wish to add for Dr. Serpil's? I highlighted a couple of points for the ERAS pathway component.
I think Dr. Serpil has mentioned lots of really, really great things. But personally, when I see my patients, I like to nag at them. And when I nag at them, I nag at them at the 3 Ps approach, essentially. So while we can talk till the cows come home about everything, but I always nag at them and tell them that pain medicines, which is the pharmacology part of things, only solves a small component of everything that you'll be experiencing in the perioperative journey. What is super important is the psychological preparation and the physical therapy. And I nag them to death and tell them that movement is medicine. So much so that one of my patients, when she woke up in the recovery, the moment her eyes opened, I asked her, "Do you remember what I said?" And she said, "Movement is medicine." She started to move her arms and her legs in the bed. So it's completely ingrained in their brain. And I think when they can wake up and they can tell me that, and I see that their parents actively encourage them to move, I'm very heartened. So all the nagging seems to work.
Yeah, thank you very much, Dr. Melody. I think all of Dr. Melody and Dr. Serpil have shared us about the components and how we're going to do it. I think one thing that I would share is that whenever we do an ERAS program in our institution, we should always make sure that the outcome measures are set ahead of time, because outcome measures will be our gauge, whether this ERAS protocol or pathway or the multidisciplinary engagement that we are doing really actually do have a change in our patient's outcome. So we need to set, may that be days of admission, pain scores, or may that be days of mobility, Instead of moving on the third day, now patients are moving on the first day. So all of these outcome measures are essential for any ERAS protocol that we are initiating in our institution. So henceforth, yeah, it is also very good for them to understand that it is also very good for the hospital in a sense, because in the hospital,
Yeah,
right,
sure.
it will shorten the admissions, you have more hospital bed, and then for the patient, they will spend less in terms of hospitalization bill as well. Dr. Bushali, you raise your hand. Yes, please.
Yes, while Melody was speaking about movement is medicine, there was one thought that emerged, which I want to share. I think to me, that line, the effort tolerance is good. Oh, he walks or he plays along with his college colleagues, or he does walk a lot, or plays, or barely walks at home. All these, I mean, if somebody says the effort tolerance is good, that's music to my ears. So I think that they are the ones we can. They tell us a lot as to what they would require. That effort tolerance history, I feel.
Yeah. Thank you very much, Dr. Brushali. Before we move on to our next question, let me share our third poll first and ask our audience about their opinion regarding this poll question. Can I launch it? Let me move first. Okay. All right. Let me move to our poll question. All right. Okay. Okay, so for our audience, which anesthetic technique? I heard that there's a lot of questions in Q&A box regarding neuromonitoring. We will discuss that in detail later. But before that, I would like to poll our audience, which anesthetic technique do you most commonly use to facilitate reliable neuromonitoring in scoliosis surgery? Do you use TIVA propofol base? Do you use low-dose volatile anesthesia, maybe low-dose sevoflurane, combined TIVA plus adjuvants, maybe flexmedetomidine or ketamine for that matter? And of course, the last one is techniques varies depending on the case that you are dealing with. So I'll let our audience answer that for another 5 seconds before I close. Okay, closing soon in 3, 2, and 1. All right. Okay, so share the results. 64% will go for combined TIVA with adjuvants. And TIVA propofol base is 28%. And very low percentage will use volatile and a variety of techniques. Dr. Serpil, what do you think?
Thank you,
For your
Teddy.
practice.
Our practice is some way we are using TIVA with adjuvants. But when we think of a global world, if they don't have the facility for TIVA, but will they have this question? They will not be properly monitoring the neurological like SSPs or motor evoked potentials. So TIVA is the best method to use during neuromonitoring to our experience. We use propofol and remifentanil, sometimes adding like some other painkillers, maybe dexmedetomidine with a special dose without exceeding too much. And our neurologists are guiding us related to the anesthesia pharmacological agents. But like we had mentioned before, hypotension, hypothermia, and other indices of that may complicate neuromonitoring, we are careful about those complications also. So as we know, propofol is good, and remifentanil or opioids can be used. And we can titrate those with, as I said before, with processed EEG monitoring, and near-infrared spectroscopy will guide us. So these are the indices we use for neuromonitoring. Regarding pain, I think one of the most important parts of these kind of surgeries, the pain. The patient will ask us about pain. The severe pain may last for at least 3 days. So we have to use effective analgesia, and for this we can use multimodal analgesia like in every other surgeries. So this pain killing will begin preoperatively, will continue perioperatively, and should continue postoperatively. As Melody said, movement is the best method, one of the best methods. So the exercises and the physiotherapist has their part in this. What else, Teddy?
Thank you very much, Dr. Serpil. So I think just to summarize everything that in order for us to have a reasonable neuromonitoring outcomes, then you will use some propofol, remifentanil, and some adjuvants like dexmedetomidine. How about the rest? Any other techniques that you wish to share? Intraoperative techniques that will for sedation and analgesia that will not compromise neuromonitoring?
Yeah, in our center, Saitama Children's Medical Center, we use DIVA technique for MEP monitoring. We almost always use MEP monitoring for the scoliosis patient, and so we use propofol and remifentanil, and we typically use a relatively higher dose of remifentanil for the maintenance. We typically use more than 0.5 mics per kg per hour. And yeah, in Japan, we have a remimazolam for a general anesthesia, and theoretically, remimazolam may be promising and may be useful without major interference with the evoked potential monitoring, but we don't have yet experience using remimazolam for the pediatric scoliosis surgery in our center.
Yeah, thank you, Dr. Nori. There's a lot of questions. Yes, Ina, yeah.
No, I'm interested. Just now, Melody mentioned that you all use intrathecal morphine, right? How do you do that? When?
Okay, all right. So this is actually a little bit of a pet project of mine. It's something that I learned from Sick Kids when I was there on fellowship. So essentially, the adolescent idiopathic scoliosis children in our hospital, if their repair level goes down to L3 or L4, the surgeons will actually give the intrathecal morphine under direct visualization. The dose that we give is about 2 to 3 mites per kilo, not exceeding 200 mites total of intrathecal morphine. In my experience, we currently have got 18 children in Singapore that have been on this intrathecal morphine pathway. In my experience, the intrathecal morphine actually lasts for a longer period of time in our Asian children compared to what is published in the Western literature. So in the Western literature, the average duration of the intrathecal morphine lasting is approximately 15 hours, thereabouts. But in our first 2 children that we did in KK Hospital, it actually lasted 40 hours, 40. So in my personal experience, what has happened is post-op day 1, the children are fantastic. Pain score 0, pain score 1, pain score 2. And if we are not careful to make sure that they have got a good amount of opioid in their bloodstream, to sort of catch that moment when the intrathecal morphine is wearing out and yet we have not quite built up on the blood concentration level, there will be a severe pain gap, which is what happened with our first 2 children, because we did not expect that the pain gap would be so drastic and happening on post-op day 2 a.m. It's a horrible time to have a sudden jolt of pain wake you up, but we learned from our first 2 patients. And over time, we sort of did mini PD assay cycles in order to tweak our protocol. So just recently in our patient this week, we switched to an OxyContin instead of regular oxycodone. So our intrathecal morphine kids do not get a PCA after operation. They get transited over to regular oxycodone from post-op day 1. But we found that because we needed to give it to them at a 4-hourly interval, the pill burden was quite high. Certain children were getting woken up every 2 hours to get Panadol, ibuprofen, oxycodone stacked 2 hours apart from each other. Really not great for the perioperative experience. So just very recently, this week, we switched to OxyContin, which is an extended release version of oxycodone given twice a day. It's worked beautifully for our first patient. So I don't know how it's going to pan out for the rest of our children. We are very excited that we can switch to OxyContin, and we are very hopeful that we can offer this to all the rest of the children, so that we can reduce that pill burden and improve the perioperative experience for them. I just want to point out and address one question with regard to DexMed in the chat about whether or not DexMed affects neuromonitoring. To be honest, when I was in Sick Kids, DexMed was banned. They did not allow it because it severely affected the signals that the neuromonitoring people were getting. In KK Hospital, the bulk of us run it at between 0.2 to 0.3 mics per kg per hour, and our neuromonitoring guys don't seem to complain too much about it. But I want to tie this in with the intrathecal morphine bit, because after I started doing intrathecal find that I don't want to stay in the recovery for my practice. So he tells me that actually the signals without DexMed, he doesn't need to give as strong a voltage in order to get the same amount of signals. And that difference is approximately 30%, even at 0.2 to 0.3 mics per kg of DexMed per hour. So I think it really has got to do with communication with your neuromonitoring guy. If you want to use DexMed, if you want to use it, you do need to let them know. You do need to be cognizant that it can have an effect upon your neuromonitoring signals, and definitely more than 0.5, I think it's a no-go.
No.
The kids did publish a paper talking about the dose dependency effect of dexmedetomidine, and therefore I would exercise caution if anyone wants to use dexmedetomidine.
Dexmedetomidine, yes. And so they are sleeping more. So we have to use, I think, with caution, with very low doses. Low doses are very sufficient to keep them calm, as far as they don't affect the neuromonitoring people. We still also, I want to add that we don't have OxyContin or we don't have methadomiline, and we don't apply intrathecal morphine since we cannot convince our surgeons to do that. So we are still using PCAs and PCA fentanyl or morphine, but we are stopping the PCA at the first postoperative day, replacing it with other medications, oral medications. So it's very difficult sometimes.
Thank you, Dr. Serpil. Dr. Burshali, you raise your hand.
Yes, I was actually listening to Melody and her take on pain management. I totally with her on that, I'm sure, because we do not have the medications that she just spoke of. So we've evolved into making our surgeons give an epidural at the end of the procedure while just before they close. So they actually thread the epidural catheter right inside the space. There were some people who did cooperate to keep the epidural. However, with instrumentations, they do not do that. And we make them give a good dose of ropivacaine along with clonidine, 2 microgram per kilogram, that aids at least first 20 hours of a postoperative period. And we have had our patients coming without the tube in the PICU. And second thing that has helped is we making them give, say, intercostal blocks while they do the costectomies, because that's very, very common, especially for the cosmetic corrections of scoliosis that they come for, and a good brace there. So all these things that really helped us in post-op management. And of course, the erector spinae block could be given before, but then that has to be absolutely in coordination and congruence with the surgical team, because they're going to put instruments worth lakhs there.
Yes, I think that's the question. One of the questions in the Q&A, you already answered, Dr. Bushali. They're asking whether what other techniques or regional techniques that we can use instead of intrathecal morphine or epidural catheter. I think there is also one paper regarding on-Q or sub-Q catheter. The problem with these catheters, may that be epidural or subcutaneous, or is that some surgeons are not happy with it because they are concerned about infection, because all of these catheters are very close to implants, and
Yes.
sometimes they're worried that this will be a cause of infection as well.
What they could do is they could just bathe the entire thing, get the catheter out and suture it. So at least we have the area flooded with local chlorine.
All right, again.
So that keeps the opioid dose very low in the postoperative
Dr.
period.
Serpil, you raise your hand again.
Yes, just want to mention the what do you think about acetaminophen? Yes, we use as a co-adjunct, but NSAIDs are sometimes used, and sometimes some surgeons doesn't prefer because of the bone healing or platelet function. What are your thoughts?
Ekta, you raise your hand.
Yeah, so I think regularly, I think I was just listening to everyone, and I think pretty much we have multiple surgeons and we follow a lot of things what everybody said. Like one of our surgeon will regularly keep the catheter despite the costly thing and is very comfortable with the epidural catheter. One of the surgeons is actually giving intrathecal morphine, and few of our anesthetists actually have directors. Paracetamol is a part of our post-op analgesia. So we do give unless if intraoperative there is a hemodynamic instability, there's a lot of blood loss, the patient was behind fluid. So like any other NSAID, the basic precaution is the patient should be euvolemic. And if that's there, then NSAIDs we do
Yeah, thank you. Let's move on. So our first question is what post-operative care elements most influence the length of stay and recovery after scoliosis? And what outcome measures? Because we discussed ERAS earlier on, right? And we mentioned that outcome measures is very, very important. And what outcome measures best reflect success in ERAS pathway? Maybe I'll ask Ekta first. What do you think about these questions?
I think quite a lot of it we have discussed, so I'll be precise. So in my experience, I feel in post-op care elements, a few of the important post-op care elements probably are the post-op pain. In this especially patient with Cobb's angle of 68, respiratory support, and the prehabilitation part of it, how early the patient mobilized, how the patient's feeling was started, hemodynamic stability intra-op and post-op, and what complications happened intra-op and post-op. Probably these are the things which in short will decide as to how long the patient will stay. I think post-op pain control we have already discussed. I will again highlight NSAIDs and paracetamol should not be underestimated. They're quite useful drugs, and in Asia, I don't know if I can talk about the whole Asia, but for sure in India, the opioid usage is always on the lower side. So we should not go by the Western literature of opioid sparing, opioid free. I think we should make sure that acute pain is nicely controlled and these patients don't go into chronic pain. And obviously, regional anesthesia as much as possible in collaboration and in communication with surgeon is going to be good. Regarding oral intake, I think other things are very self-explanatory. Mobility post-op day 1, they get to stand. I will not say they are mobilized, but they get to stand and do a little bit of standing business. But within 48 hours to 72 hours, they start to move. Children always easy to handle mobilization part if the pain control is good. So that's not an issue. Coming to oral intake, as early as possible, there is no reason why we should not start early feeding. The only problem we see is if the pain is not well controlled, and there are a lot of opioid going in, and then you are not given antiemetic, then they start vomiting. That's where things start to go wrong. So I think these are the things. In this specific case, I think we have to be careful because there's a lot of correction. So probably NIV is a good way to bring out this child after extubation.
Yeah, thank you very much, Ekta. I think since it has been highlighted almost all throughout the webinar so far, that movement is medicine. And of course, Dr. Ekta just mentioned it just now. I'd just like to poll our attendees. Let's say how soon in your institution, right, when children usually mobilize, how soon they usually mobilize after spinal fusion surgery. So I just like to know whether do you have a standardized protocol? Do you ask them to stand on the same day, the moment they reach the ward and all that? So we just want to know how soon do you actually mobilize that? So while our attendees are answering, Ekta, maybe I'll ask you, what is the role of acute pain service? You mentioned about that we should not let acute pain not treated, and we should actually use some level of morphine or some level of opioids together with but therapy. But how soon
I think
engage in
physiotherapy and
your
movement is the way forward. So if you tell everything preoperatively, you call it nagging. I say you're very, very careful about your patients. So I will not call it nagging. I mean, I will call it how careful you are with your patients. So I think if all these terms have been in preoperatively so beautifully that the patient wakes up and movement, I think there's no need to do anything else. I think it's already gone in the brain so well that this patient will put all the effort to make sure he moves, and acute pain service. I think one thing which I've noticed is there's no point acute pain service going and seeing patient at 8 a.m. in the morning and the physiotherapist coming at 10 a.m. in the morning and nobody knows what is happening. So I think at least first few rounds should together, where when physiotherapy is getting done for the child, the pain team should be there making sure the needs and requirements are assessed and measured, and rest can follow. As the days pass, the pain will come down. 1-2 days are very, very crucial because children, the moment they have trust in you, they do whatever you say. The moment they lose trust in you, they just don't do anything what you say. So very, very important initial few days.
Yeah, very good points,
so
Dr.
I think
Ekta.
movement
I'd
is
just
the
like to
key.
share the results of our poll. 52% of our attendees will ask their patients to move on the post-op day 1. Hopefully, after this webinar, the 52% will be 90% of our attendees will mobilize their patient and post-op day 1. And I do agree with Dr. Ekta about where acute pain service should be around during, at least for the first mobility of the patient, because so that the pain and the movement will go hand in hand, and we will also know what are the requirements of the patient. Of course, different patients will have different requirements, different opioid requirements, and different tolerance in terms of pain as well. So being present during the mobility is also important. In our center, initially, our physiotherapy will only see our patients once. But after some review and some ERAS and early mobility protocol as well, we actually managed to convince our physiotherapists to review our patient twice a day on weekdays. So they will come on the morning and then come back in the afternoon. So they'll have 2 physiotherapy sessions. So sometimes during the post of day 1, right, in the morning after surgery, they're very sleepy. They're not very cooperative yet. Some of them are not morning person. I have one patient who told me, I'm not a morning person. I'm going to move in the morning. So that's why the mobility in the afternoon helps, because we gave them another chance to able to move on post-op day 1. Maybe other points or other answer apart from Dr. Ekta, maybe Dr. Nori. How about in Japan? How about the mobility in Japan?
Yes, I agree 100% with the Ekta. Pain management is like a key of the early mobilization, and the early mobilization is the like a key for the working with the patient toward the early motion. The pain management, we usually send our scoliosis patient to the PICU, and during the PICU, they use IV PCA with morphine or fentanyl. The day of the surgery, PQ physician usually use dexmedetomidine to provide some sedation and analgesic support. And after the PQ discharge, they usually move to the high dependency unit, HCU, and they will spend a few days there. And after switching to the oral medication, they go to the regular ward. That's our like a pathway.
Yeah. Thank you, Dr. Nori, for sharing your protocol in Japan.
And we use NSAID and acetaminophen.
NSAID.
Yes, our surgeons are happy with the NSAID.
Mm.
But during my fellowship in the US, most US orthopedic surgeons are not happy to use NSAID. So, yeah.
Dr. Brushali, you raise your hand. Yeah, you're muted, ma'am. Thank you.
Wanted to share two thoughts in 2 lines. In our post-op period, as Ekta was mentioning, we need not keep them fasting for a long time, but we just make sure that we hear the bowel sounds because we're giving a lot of opioids here as well. And we make sure that we give metoclopramide because that actually opioids, and unfortunately here, opioid is going to be the mainstay.
Okay, you're using metoclopramide as
Yes, we do. We make it a point. In fact, if you go to the palliative care therapy, they are the ones who really make it a point to say that for opioids, it's MSET, of course, work, but a better working agent is metoclopramide.
And understand, yes, it is actually quite helpful, especially if the nausea and vomiting is triggered or initiated by postprandial or eating. But otherwise, I think other agents is also available. If it's available at your center, you can have ondansetron as first line. Sometimes they will use dexamethasone as well. But of course, we can use whatever is available in our center for as long as we have antiemetics. And I do understand that ill use or those abdominal pain also comes with as a consequence. I actually, when we look at the literature, right, opioids is one, but it's not as much as what we think. It is the main ill use after spine surgery. There are some evidences that we say, yes, it can, but it's not as much as, let's say, if you have a poor perfusion during the intraoperative period, meaning that you have lost a lot of blood that you didn't actually catch up, that also can lead to ill use as well. And mobility is medicine. If the patient is not moving, right, you will also have, regardless of whether you use opioids or not, because we noted that even our patients with low opioid utility, they will still first or second post-operative day. Then they were still going to have abdominal pain. They were still going to have bloating and ill use. So it means that, yes, opioid can cause that, but there are other culprits for our ill use or abdominal distension. Dr. Serpil, you raise your hand. Yes.
Thank you, Teddy. You had mentioned some of my points. I forgot to mention dexamethasone. It's one of our routine medications regarding the nausea, vomiting, and also the edema and pain. And also we use ondansetron in our PCAs. In PCAs, we put ondansetron so that if somebody forgets to order it, so especially for the first postoperative day, it's very helpful to keep them nausea free. And a long fasting, the feeding and the regarding ERAS protocols. So regarding the newest fasting guidelines, it's very helpful to keep them carbohydrates before the operation and less fasting times and clear fluids 1 hour before. So
Dr.
it's
Ekta,
I'll just keep it very. I'll keep it very.
Thank
I just wanted to highlight one point with the use of, because I thank Dr. Vishali to raise it with perinorm or metoclopramide. I think extrapyramidal side effects in this age group are quite common. They are not rare at all. So we just should be looking out for this. So we actually don't use perinorm so frequently, especially in this age group.
Dr. Ina?
Yeah, I was just going to echo what Ekta said.
I think you are a little bit. Yes, Dr. Ina? Yeah, I think what Dr. Ina is saying.
After it's been given by a patient, by a surgeon to the patient. So they normally are quite good with ondansetron and dexamethasone. Yeah.
Yeah, thank you very much for all the inputs. Yes, I think one more thing before we wrap up. I think one thing that we need to be well, apart from Bill mentioned that you gave opioids and all that. Following that, 48 to 72 hours, that's when the spasm kicks in. Like some of the patients will complain more about spasm pain rather than the sharp pain on the 48 to 72 hours. So please do give your antispasmodic. We have some options. We can give diazepam as antispasmodic. You have orphanadrine or some other things. So all of this you can search, and all, but majority of it, actually, the side effect of this antispasmodic drugs is sedation or sleepiness and all that, and drowsiness. So you need to balance all of your medications in such a way that you will not going to put your patient into too much drowsiness that they cannot mobilize. So remember, mobility is medicine. So at least your antispasmodic, you can give it at night. They have a good night's sleep with diazepam. Then the following day, they are fresh to move and mobilize as well. Yeah, so that's one thing. Yes, Dr. Ina, you are okay. So I think more or less we are clear. Anything else? All right. Okay, I'll hand over to Viva now.
Right. Thank you. Thank you, Teddy. I think we had wonderful discussion, and as we reach end of our scheduled time, we have to wrap this up. I wanted to thank all our attendees for their active participation. So many questions that came in, most of which I think our panelists have answered. And if there isn't anything that you would want to know more, we would be happy if you send an email to us. Also, some of the aspects that we could not have covered are available in this YouTube video on scoliosis, which is available on the ASPA YouTube website. Next, yeah. And I had already mentioned about the certificate of attendance. You would get the survey link tomorrow. Please ensure your correct name and email you've entered in there. Stay tuned with us for our next webinar, ASPA, by the Pediatric Sedation SIG, and we will shoot out the details soon. Wanted to remind you that ASPA is a nonprofit organization, and we seek your donations to help us in our cause. I hope you've checked out the latest issue of ASPA newsletter, the ASPA Connect. This has been mailed to you just a couple of days back, but in case you haven't seen this, you could reach out to the ASPA website, and we've uploaded this there. And let me extend a warm welcome to all of you to the next ASPA newsletter, to the next ASPA conference in India in September at Christian Medical College, India. And we welcome you. The abstract submission is open, so please submit your abstract. We've also been running brain teasers, and remember that you need not have to register for the conference to be a part of this brain teaser. And actually the brain teaser can fetch you some discounts in registration. So the next brain teaser is on 31st May. The topic is on guidelines. So please make sure that you're part of this brain teaser. And with this, I think I'm happy to wrap up. thank you so much for attending. Please follow us. You could reach out to our website, the YouTube link, our Instagram profile, and our Facebook page. So thank you so much, everyone. Thank you, panelists, and a very good evening. Looking forward to see you at ASPA 2026 in India. Bye-bye.
Thank you, everyone.
See you. Bye-bye. Bye-bye. Thank you.